time to participate in the safety and faith. If this is like many of the other safety and faith events that we've had, I typically ask people to raise their hand if they are attending for the first time, and roughly about half of the hands in the audience will go up. Certainly, we can't ask that and see that today, but I would make that presumption. And so, with that in mind, and those of you who've heard this before, I guess you get to hear it again. Um, Several years ago, I was attending a conference in Washington, D.C., sponsored by the Federal Bureau of Investigations. The National Executive Institute is actually the program that it was. And when we were in the second session, and we had a free evening, several of us went to a Washington Nationals baseball game. And it was when I was at that baseball game that Al Cannon, who is the sheriff in Charleston, South Carolina, got a call from his number two in charge of the department, and he was advised that there had been a shooting at a church in Charleston, South Carolina, the AME church down there. And obviously it was upsetting to Sheriff Cannon, and he needed to get back home. Obviously, many of us know that that made national and international news, and still does a little bit. But I walked Sheriff Cannon back to the hotel. We rode on the subway back to the area where our hotel was, and as I was walking him back, just guiding him where he was supposed to go, I was able to hear his side of the conversation, and I could imagine the other side of what was going on. And one of the things that I picked up on was that that he had a connection to members of the faith community. And when I got back to work the next week, I had asked my staff in a staff meeting, how connected are we to our faith community here in Jefferson County? And while I think we had done a pretty good job up until then, the answer was we could do better. And that gave the idea to initiating the Safety and Faith, the conference that we put on each year, aimed at providing overall safety information to leaders in houses of worship, not faith specific, not necessarily venue specific, but how could we provide information regarding safety? Much of that has involved security, as it did in Charleston, South Carolina, and as we've had events here more locally in years past. But also the approach that we wanted to take was to make sure that we were holistically looking at safety. Anything from how do you prevent a 5-year-old from drowning in a baptistry, which had happened in a different part of the country, or a candelabra that was lit at Advent, igniting a wreath on fire that was above it. How do you prevent those things? And just asking people to consider those, as well as those things that tend to get the news headlines, the shootings that all too often have happened in houses of houses of worship. But how do we provide that information? Well, we all know we're in a different world right at the moment, and safety has taken on an entirely different meaning, something that we couldn't have conceived, I don't think, when we had initiated the Safety and Faith. But nonetheless, it is the circumstance that we have, the circumstance of the safety of the health of our community. As I was having a conversation with Pastor Dave up on Lookout Mountain on the phone, a couple of conversations just a week or week and a half ago, the idea was that we can't necessarily stop having these conversations about safety and faith. We just have to change, one, the topic that we're talking about in this circumstance, and two, the method. This isn't my preferred method of communicating with you or any other audience. I would rather see you face to face. I'd rather be able to shake your hand. I'd rather be able to answer the questions with you standing right in front of me. And I'd rather all of us be able to get to know one another a little bit better, because that also had been the goal of the Safety and Faith, is to know each other a little bit better in the event that we had to deal with things. But I'm thankful that you trust us today to come back on this phone call, this video conference. and listen a little bit about what is going on in the state, more importantly, what is going on in Jefferson County, and how we address the things that are in front of us and the different roles. The COVID-19, the response to the COVID-19 circumstance in Jefferson County, this is a public health event, a public health crisis, and the role of the sheriff's office is to provide support, one, through our emergency management function, and secondly, in making sure that we do what we always do to make sure that the peace is kept and that people are safe. And as many of the decisions that have to be made in this regard are made at the public health level, I thought it would be appropriate that the leaders of the public health, Jefferson County Public Health, come on and talk to you about what is going on specifically as it relates to churches and houses of worship. And so I've asked Dr. Johnson to come on. I'm going to ask him to speak second. But before we talk to Dr. Johnson, I'm going to ask Christine Billings, who is an epidemiologist with the Public Health Department. And also, she is the incident commander for the COVID-19 response and the incident commander in the Emergency Operations Center. A lot of things have gone on during the course of the last 8 weeks, a lot of different orders, a lot of different things that we all have to get our brain wrapped around. And some of the best places to start is with information. And I think that's what Christine will be bringing to us. Christine, again, is a trained epidemiologist, and she has a master's in public health, and she's been leading the Jefferson County Public Health's emergency preparedness and response efforts for the last 12 years. So it's my pleasure to introduce to you Christine Billings. Christine, welcome and thank you for being here.
Welcome to all of you. I'm sad I can't see you. I am in my personal life, I'm quite involved in my faith community down in Castle Rock. So I very much appreciate seeing people face to face, but I recognize we are definitely dealing with a new normal here as we fight this pandemic. As Sheriff Shrader said, I have participated in local public health for the last 12 years, falling into emergency preparedness after studying epidemiology, which is the science of disease control and prevention in populations. Received my undergraduate degree from the University of Denver and then a graduate degree from the University of Michigan. I have 3 children who you may see running by my screen. We have a new puppy who doesn't necessarily like to stay put very well, so hopefully that is not too distracting to you. I wanted to present some of our numbers to you today. I'm sure you can see them if you've moved around our Jefferson County Public Health website, but I wanted to again reiterate those to you. As of 4:30 yesterday afternoon, we've seen a total of 1,925 cases in our community since we started, had our first case occur, confirmed case within Jefferson County on March 10th. Some of these cases are ones that we identify by a tool called contact tracing. So when we get a positive case of disease, we do an investigation around that individual and identify those that may be symptomatic who might not have been tested. So some of our case counts are coming from that. Some of them are coming from testing that we have across our community. And then some of them are suspect cases where we've identified that they are symptomatic, they haven't had a test, and they don't necessarily want to go get tested. So we have that bucket of individuals leading to this total case count that we have. We have had 105 deaths across our community, and of those, 62 of those are tied to outbreaks within our long-term care facilities. So our elderly population is definitely being disproportionately affected by the severe outcomes from this disease. We have 16 outbreaks occurring in our long-term care facilities. That's about 10% of our long-term care sites that are suffering from outbreaks within them. We do also have other outbreaks across the community that we are dealing with as well within a couple child care centers, correctional facility, as well as a couple related to places of business as well. When we look at our hospital system, so one of the indicators that we look to when we released and moved to this safer at home order was the ability of our hospital system to be able to care for the most severely ill within our population. And when we look at that health and medical system across what we call the North Central region, which is the Denver metro area, we are seeing that the healthcare system is able to care for the most ill within our population. If we look statewide, currently we have, as of 5 minutes ago, 514 patients who are admitted within the state of Colorado within facilities. We have capacity of over 1,200 ventilators in our Denver metro area that could care for severely ill. We are seeing a little bit of potential for staff shortages, and that's not because of the disease. It's because the hospitals have started to open up to a few more elective procedures within their facilities. So as staffing moves around, they anticipate that they may have a shortage if we do see a sudden rise in cases of COVID-19 across the community. Another piece of information that we look at is some of our ethnicity data. And one of the populations that is definitely being hard hit is our Hispanic population. They're slightly over 20% of our cases, and they only make up about 15% of our population in the community. So that's what we call disproportionately affected. So we are working hard to make sure that the most vulnerable in our population can access testing resources. We've stood up community sites and community care services within our emergency operations center at the county level in collaboration with numerous county agencies as well as nonprofit and community partners to address the vulnerable and those that can't access resources as best as possible. We are also looking at testing across our community. One of the numbers that we need to reach is about 880 tests being conducted per day across our community. We have some community testing centers that have been stood up across the community, as well as we are working with our long-term care partners who have had some targeted efforts that you may have seen in the news. If you look at our case count, some of these large bumps in data have come from these targeted testing efforts that we have undertaken. So it's not surprising that we would see an increase in cases as we see an increase in testing. I believe that's everything that I had to present today, and I will turn it back over to you, Sheriff Shrader.
Thank you very much. And we're going to transition here in just a couple minutes to Dr. Johnson. And again, very helpful to have some of the background information. And I'm going to add just a little bit of context to that for what I see locally within the areas of responsibility that I have in being your county sheriff. And in that regard, many of you know that the sheriff is responsible for patrolling the unincorporated portions of the county as well. I also have the responsibility, statutory obligation to run the county jail. And we have worked very, very diligently to do everything we can to not have any of our employees get sick with COVID and not to have the virus introduced into the jail. And in spite of our best efforts, in spite of having 14-day quarantines on everybody who's booked into jail and reducing the jail population by 51%, we did have an outbreak last week that spreads fast. Similarly, we have had 11 or 12 employees that have been infected with COVID. Several of them are back to work. Some of them are still out. Some of them have just found out, and we're waiting on tests on 7 or 8 other individuals where we're just waiting on word what their test results have been. One of the points that gets made is in congregant living areas, like Christine talked about, in nursing homes or in a correctional institution, there is a high likelihood for infection. And that informs some of the policy that we have in terms of some of the business operations that we have open in the sheriff's office and restricting movement into the sheriff's office. And so we've taken many steps to provide services in a different manner. As such, many of those are informed by public health policy. But it also helps to keep in mind that while we're talking about safety and faith, it is all segments of our community that we are dealing with in this. And here shortly, I'm going to turn it over to Dr. Johnson, and I'm going to preload a couple of questions that have come to me for Dr. Johnson. And I don't think these will be a surprise to him, but leaders of houses of worship, pastors, and other leaders have been asking, well, what can we do to bring our people back together, absent having video services? How many people can we have in a building or in a room? And how soon can we expect to have larger gatherings in our houses of worship? And I'm sure Dr. Johnson was going to talk about some of those things anyway, but I figured that I would also put those out. But Dr. Mark Johnson is the executive director of Jefferson County Public Health, where he has served in that role for the last 30 years. He received his medical specialty training and Master of Public Health at Johns Hopkins University in Baltimore, Maryland, and became board certified in preventive medicine and public health in 1988. I've known Dr. Johnson for many of those 30 years that he has been with Jefferson County. He is as much of a gentleman as anybody I have ever met. I'm honored to call him a co-worker at Jefferson County and privileged to have served on many boards and meetings with him. And I'm pleased to introduce to you Dr. Mark Johnson.
Thank you very much, Sheriff Shrader. I too have felt that it has been a great honor for my career to be able to work with you and your cohorts in the Sheriff's Office. I have known you for many years, as you mentioned, and have always found you to be very well prepared for all the meetings that we have and well read as to what's going on. So thank you again for the opportunity to work with you and to talk today to this group. Since Christine shared a little bit about her personal faith journey, let me just share a little bit. This may surprise even the sheriff and Christine. I was actually born in a mission hospital in Ethiopia, Africa. My father was a missionary doctor, and I lived there till I was about 5 years old. I went mainly to parochial schools throughout my educational system, and at one point thought I might even become a pastor or a minister. Having become a physician, my wife is a nurse, a labor and delivery nurse. My wife and I and our children have actually been on numerous medical mission trips to places such as Belize, Nepal, and the Kingdom of Tonga down in the South Pacific. In my own congregation, I do go to church almost every week, at least when the church is open, and I do get online every week now. I am the chairman of the church board and do teach a class. So faith is a very important part of my life as well. And as we have been working with this pandemic, it has been a real issue for me to try to figure out how can we continue to have these services and the great contributions that churches bring to our residents under the circumstances under which we find ourselves. Let me talk a little bit about the legality of what is going on, just to give you a background, and then I'll talk a little bit about what we hope we can do as we move forward, trying to answer the questions that the sheriff raised, and then also maybe give some suggestions to those of you who are working in churches and synagogues and mosques and other places of worship. In The Colorado statutes, it says that it is the responsibility of the local health department, the local health agency, to protect the health of the residents of the jurisdiction over which they reside. One of those areas talks about infectious diseases and what happens when we have an outbreak of infectious diseases in the community. And under that portion of the statutes, it says that it is our responsibility as an agency to close schools and public places and to prohibit gatherings of people when it is necessary to protect the public health. We also have the right to exercise physical control over property and over persons within the jurisdiction if we find it necessary to protect the public health. That's the legal authority that we have to do what we have done. The logical or the more practical reason we have done what we have done is that with COVID-19, we are facing what is called a novel virus. This means that nobody has seen this virus before. Nobody has immunity to this virus, at least when it first came into the country. There is no known treatment for this virus, and there is no vaccine for this virus. So what we essentially had is what we call a naive population, a population that had not been exposed ever before to this virus. Some of you who know your history may know that one of the reasons the Europeans had such an easy time settling North America and Central America was when they first came to this country, they brought with them viruses to which the populations in this area were naive, particularly smallpox. And as smallpox spread through the population in Central America and here among the North American natives, it decimated them. And so anytime we have a new virus in a naive population, we take it very seriously and we try to determine how contagious is this, how severe is the disease that is brought by this, and how can we control it. As I mentioned, without the controls that we commonly use for infections, such as treatments and vaccines, we really fell back on some of the early public health principles that were established back in the early 1900s around the influenza pandemic of 1918 and some of the other pandemics that we had back then. And those were essentially social distancing, keeping people separate so that the contagion did not go from person to person, isolating people who were infected so that once somebody was determined to have the disease, isolating them away from the population as much as possible. Then doing what's called contact tracing, which means you find everybody around that person who is infected, who has been closely involved with that person, and you do what is called quarantining, or we now call it self-quarantining because we don't usually give an order to quarantine. And those were really the only tools that we had as we began to have this new novel virus hit in America. So we have been using those to the greatest ability possible to try to keep the number of individuals who are infected as low as possible for a couple of reasons. One of those is we did not want to overwhelm our healthcare system. We didn't want to see a huge spike in very severely ill individuals who needed to be in the hospital, who needed to be in the intensive care units, and who needed to use ventilators to help them breathe because we have a limited number of intensive care units, of hospital beds, and of ventilators. That's why we put into place the social restrictions of gatherings. That's why we began by saying those places where people tend to congregate the most, we need to stop those gatherings. We need to stop those congregations from getting together. That included places like schools, so the schools were closed. It included places like sporting events, so the sporting events were closed. It included places like restaurants and bars and other places of social interaction. And it included places of worship, because that is one of the main purposes of a place of worship, is to bring people together, to bring a congregation to gather together, and to closely share in their worship services. So those were the first kinds of things we looked at and said, we have got to do something about these social gatherings so that we can keep that social distancing. So many of those places were closed right at the beginning. And as we continued to see a rise in the cases, we expanded that to actually the whole population, what was called the stay-at-home order, where those who were determined not to have what have been called critical or essential businesses were asked to stay at home as much as possible, only going out of their homes for things like buying groceries, going to the pharmacy, those kinds of things where they had absolute necessity. In Colorado now, we have moved into what we call the second phase, the safer at home phase, where we are saying for those vulnerable populations, people who are older or who have conditions that cause more risk, they should stay at home. They should keep in that first phase. They should do as little as possible about getting out and about, and we should keep that stay at home as much as possible for them. For those other entities, however, that were called non-essential or non-critical businesses and workplaces, we're beginning to open those up a bit and allowing them to act more like the essential businesses were acting during that stay-at-home place. However, one of the things that has been continued in the governor's stay-at-home order is limiting the size of gatherings. Unfortunately or fortunately, but at least causing some problems, is the term gathering is not defined. And so we have had a lot of questions from our places of worship and from the leaders of our congregations asking, what exactly does a gathering mean? Does that just mean in my sanctuary? Does it mean in my whole place of worship? What if we have 10 people in some classrooms? Does that count? And so we've had a lot of time spent both with me and our county attorney trying to work with the governor's office and with the state health department, getting a better understanding of what do you mean when you talk about a gathering. The advice that we have gotten is that it continues to be a place where people get together like a sanctuary, that if 10 or more people get together in a sanctuary, it is the interpretation, at least of the state health department, that that's a gathering. Probably most of you know, if you have been leaders in churches or in places of worship for a while, that there are certain laws in the United States that are very protective of our ability to worship. That's one of the founding principles of this country, was our freedom to worship, our liberty of conscience, and our ability to gather together to worship the way we wanted to. A couple of the things that we have to do is, in any sort of orders or limitations that we put, we have to find the least restrictive way of doing it. And so we have looked closely, is this the least restrictive way that we can limit these gatherings in places of worship? We also have to make sure that it's non-discriminatory, that we don't treat places of worship different than we do places of commerce or other places where people gather together. That has raised an issue because there have been some gatherings that have been allowed by the governor's office and by the state health department for graduations with certain restrictions, but at least allowing people to get together in a way that perhaps some of the churches or places of worship would like to do, that we have been saying you can't do. And so it has raised more questions around that. And as we have looked at this, we have determined in Jefferson County, if schools and graduations can get together in certain ways and not be counted as 10 people meeting in a gathering, we have to look very closely at, are we being discriminatory towards places of worship? So we are taking a good look at that. We are working both with the governor's office and with the state health department to make sure that whatever we are telling you is not discriminatory against places of worship. What we're doing now is we are encouraging places of worship to do as much as they can without gathering in one place. As I'm sure all of you know, most of you probably now have online services. You're able to either live stream or Zoom or something else to have those gatherings at least as much as possible in a virtual way by remote viewing. And that will continue as we move forward to be the optimal plan for what we have called the vulnerable population. those people who are over 60 or 65 years old, those who are older, those who have other medical conditions that put them at risk. We will continue at every phase, at least until we get back to where we have a wide open society. We will continue to encourage you to continue to have those virtual meetings with those vulnerable populations. So even as we move forward with perhaps allowing more people to gather together, we would still encourage you to have those kinds of meetings, those kinds of opportunities for those who are most vulnerable in your population. We also are going to continue to have limitations in the numbers that are allowed to gather together. Right now, the governor's plan puts that at 10. Again, like I said, we're trying to figure out, does that mean we can only have 10 in a sanctuary and 10 in a classroom? Or is there a way of possibly allowing some social distancing in a sanctuary that allows more people but still keeps that social distance and keeps that hygiene between people at something that is going to protect the health? As I said, we're still searching for an answer to that question. As we move forward, though, into the next phase, as we get more into the safer at home phase, the governor has said he's going to be reviewing how the disease has responded to the bit of opening that we have already had. And if it looks like we are still able to control the spread of disease and we're able to control the numbers of people who are coming into the hospitals, we're not overwhelming them, he is talking about, even during this phase, perhaps opening it up a bit more. He has not mentioned the numbers, but the Colorado Association of Local Public Health Officials have looked at this and have determined that we feel, at least in the second phase, we might be able to move up to groups somewhere between 25 to 50 in the second part of the safer at home phase. That still does help most of you and your congregations, because I know some of you have congregations of thousands, but at least it is beginning to open that up and beginning to say that more people can be included in a gathering. The third phase then moves up to about 250. It still does not go to the full number that many of you may have in your congregations. But again, we're trying to take these steps slowly so that we slowly open society. We watch to see how the disease reacts to that opening at each stage before we get back to the point where we are able to completely open up us back to the way we were, where people can go to theaters and can go to sporting events and can go fully to places of worship without having about the numbers. At each of these stages, though, I must underline that we are still concerned about those who are in the vulnerable populations and limiting the size of those. The other area we're very concerned about is, how do we make sure that where people do gather, whether it's in 10 or 50 or 250 size audiences, how do we make sure that we are keeping the areas there clean? And so there are certain safety actions that we are asking people to undertake as they begin to get together more and more. One of those is using face coverings. There has been a lot of discussion about mask orders. You may know that in Jefferson County, what we are doing is we are strongly encouraging the use of face coverings, but we have not put into place a mandate. We are not requiring the use of masks, at least on a whole population basis. We are allowing businesses and governments and organizations to determine for themselves whether they require a face covering when you go to do business with them. But on an overall basis, we are not requiring that. But I would strongly encourage, as we begin to increase the number sizes of the groups that are gathering in your places of worship, I would strongly encourage the use of face coverings. A lot of science has been looking at face coverings, and one of the things that is absolutely true is that if you have a face covering on and you cough or you sneeze, you are limiting the size of droplets or the droplets that spread out from you when you cough or sneeze if you do not have a face covering. That is one of the main ways this virus is transmitted, is by those droplets that come out when some people just when they talk, they spray quite a few droplets. Others with coughs and sneezes, it increases the amount. So wearing a face covering does protect those around a person from any sort of spray or droplets that are coming from that person. So we strongly encourage that. Wearing one yourself does decrease a bit of that, but there still is a lot of air that gets around a face covering, so it is not quite as good for the person who is wearing it to prevent getting the disease as it is to prevent the person who is spreading the disease from spreading those droplets. So again, we encourage very much a cloth face covering when you begin to have more people in the group, or actually right now. We also stress those healthy hygienic behaviors that you've heard a lot about: washing your hands, using hand sanitizer, coughing or sneezing into the crook of your elbow, using tissues, washing your hands again, don't touch trash cans, don't touch your eyes, your face, your nose, your mouth. So as you begin to have more people coming back into your places of worship, we would really encourage you to have signs around and to encourage those of the leadership to be reminding people of all of those hygienic behaviors to help stop the spread of disease within your group. Also, cleaning the place, cleaning the places that are touched in your place of worship, particularly those surfaces where a lot of people may touch them: handrails, the back of pews, various places, shared objects, those kinds of things should be cleaned at least daily and as much as possible between use if shared objects are going back and forth. Avoid using things that are hard to clean, so things that are have a lot of cloth on them or other kinds of things that are difficult to clean. If possible, try not to use those as you get back into having services. Ensure that there is a safe and correct use of whatever disinfectant you have, so that you're not causing problems with the disinfectant, particularly around children. And then one of the things that seems to be becoming more and more known about this is to have good ventilation systems. And I don't mean systems that necessarily recycle it in your place of worship, but that brings in outdoor air through windows and doors and helps to recycle the outdoor air with the indoor air to help decrease the number of aerosol particles that you have within your place of worship. Another thing to be cognizant of is, as you begin to open up your place of worship, if the water system has not been used for a while, be sure that you run that for a while so you decrease any problems with possible things like Legionnaire's disease or other things that may have accumulated in that while it has not been used. Those are some of the basic things that we would encourage anybody who is in charge of a place of worship to be thinking about. As I said, there will be several phases as we move forward where we begin to expand the numbers that are allowed. That partially answers what can we do together while we're not able to worship in our sanctuary. Again, I would encourage those virtual meetings as much as possible. Also, we have been encouraging people to have drive-in services where possible. And very soon, we're going to be encouraging people to get together more, as long as you are keeping social distancing in outdoor places. If you have a large grassy area where you can get together but keep those social distances, that I think is going to be very soon on the list of things that the governor's order will allow. How soon will we get larger groups available? It depends on how the disease responds to the actions that have been taken as we move from stay at home to safer at home. We are watching very closely right now several things. We're looking to see, are we seeing a rise in the number of cases? Are we seeing a rise in the number of hospitalizations? Are we seeing a rise in what we call the positivity rate of those who are tested? Now that we're able to test more and more, it's going to be natural that we have more cases. But as we test more, we should also have a whole lot more negative cases. And so watching the positivity rate is another thing that tells us whether the disease is on the rise or if it's on the fall as we open things up. The anticipation is that we'll be in this stage probably between 4 and 6 weeks as we again sort of watch for a couple of incubation periods to see what has happened. We will then move into the next phase of the governor's orders, the protect your neighbor phase, and we will again monitor very closely with good surveillance around the community to see what is the virus doing. Is it expanding its scope? Are we getting more hotspots? Are we getting more cases? That probably will be another 5 to 8, maybe 6 to 12 weeks where we have to watch closely to see what happens. So essentially, we're talking about at least going through the summer, where we are going to be slowly expanding up to probably groups of 250 by the end of the summer if everything goes well. But I don't anticipate that we're going to be seeing sporting events and places of worship with large crowds anytime soon, at least within the next 2 to 3 months, probably even longer than that. I've thrown a lot of stuff at you. I've had a lot of words. I would be happy to answer any questions, or Sheriff, whatever you would like to do at this point.
Dr. Johnson, thank you very much. And yes, there are going to be a few questions. I have seen a couple that have popped up. And as Jenny mentioned at the beginning, and I'm sure several people weren't on at that point, but we would like you to forward your questions via the chat app. Is that the correct one, Jenny? The chat?
They can use chat or Q&A. I'm getting questions on both of them, and I can go back and forth and make sure we cover all the questions.
Yes, and Jenny is going to be going through some of those questions. We'll answer all that we can so that we can conclude by 2 o'clock this afternoon. We set this for 1 hour. She will, if there are questions that are substantially similar one to another, we're not going to ask every question that comes up. And if there's, numerous questions from one individual, we may not be able to answer all of your questions, but we'll do the best we can. So Jenny, if I could turn it over to you to start posing those questions for Dr. Johnson or Christine, or if they happen to be for me, I'm happy to take those too.
Sure. I'll just go in order that the questions came in. So this one's for Christine. Can you explain how, where, and when people may have access to antibody tests? This person says that some of their acquaintances think that they had COVID early on, but never got tested and are interested in finding out more about antibody tests.
Yeah, thank you, Jenny. I will fill in a little bit about testing location data, and then I might ask Dr. Johnson to speak to the antibody tests that are available and what they show us as far as disease burden within the community. I do know that several of our urgent care sites across Jefferson County do have antibody tests that are available. I also know that they have the more highly preferred version, which is the PCR test, which shows active disease. So they are testing symptomatic folks. That data is available by calling 211, and we are also working to get those locations put up on the Jefferson County Public Health website. We're also doing a big survey launch today to our health and medical providers across the community to allow us access to data of who's doing testing and what the availability of those tests are for community members, including those who might be uninsured and unable to pay for testing.
This is Dr. Johnson. Let me just address Jenny, if that's all right. Talk a little bit about, as Christine mentioned, there are two main categories of tests. One actually looks for a particle of the virus that causes the disease. And if you find that in the test, it basically says that you are infected with the virus. The other type of test is called a serological test. It's where you take some blood and you look in the blood to determine if somebody has antibodies against the virus. What that tells you is it tells you that a person has the body of that person has been fighting that virus. So at some point they have been exposed to that virus. It doesn't tell you whether they are sick right now. It doesn't tell you if they are contagious right now. It tells you that somewhere in the past they were exposed to this virus and their body fought against it, making antibodies against the virus. Several things that tells us then is it can tell us if the person has a high enough level, it can tell us that perhaps using some of their convalescent serum, by getting some of those antibodies, we might be able to use that to help people who are severely ill fight the disease because their body is not making antibodies fast enough. So we give them antibodies from somebody else. What it doesn't tell us is it doesn't tell us how long you may be immune to the virus. Now, what we're trying to do is we're trying to figure that out as much as possible. The coronavirus that causes this disease is related to a number of other coronaviruses. Some of those cause the common flu every year. We get coronaviruses almost every year. So everybody in the country has been exposed to some kinds of coronaviruses when they've had colds, basically the common colds, not the flu, I misspoke, common colds. So with common colds, quite often you will get some antibodies to coronaviruses, and some of these tests that are doing serological testing are not able to discriminate between this coronavirus and the other coronaviruses that have caused common colds for years. And so again, it doesn't tell us for sure what your immunity is. If, however, you do have antibodies against this particular coronavirus that is causing COVID-19, we don't know if that lasts for weeks or for months or for years. We do not know. The best guess is it probably lasts about a year to a year and a half, because that seems to be what the coronavirus antibodies against SARS and MERS and some of the other more serious coronavirus infections have caused. So again, why would you want to get this test? One of those would be if you wanted to donate your serum to help fight if you had high antibodies. Getting the test just to know that you had the experience probably is not going to be all that helpful. You may have read that some countries are saying if you get a serological test and you have antibodies, that's your go to work free card. It means you're okay to go to work, you're safe. In this country, we are not asking for those kinds of things, and we don't believe it really tells us yet whether you're safe to go to work. All it does is it tells us that you have been exposed. So what we're really looking at is we're probably not going to be doing widespread population serological testing. What we're probably going to be using those tests for is in certain populations, like healthcare workers, to try to find out how much is this disease spreading through this population, and we didn't know it because they were asymptomatic, but yet we can show that they have antibodies to this. So the way we use those tests is going to be limited, and seeking out to get that test, it may make you feel better, but it's not going to give you a whole lot of help unless you really are planning on using it to give your serum to help somebody fight the disease.
Thank you, Dr. J. The next couple of questions I know that you touched on when you spoke earlier, but just to clarify, one thing that we have learned recently, I think the state came out with this guideline on May 8th, is that groups are allowed to gather up to 10 people in separate rooms at houses of worship, as long as the rooms have 4 walls, and that's how they're separated. So if there's classrooms or other meeting rooms, then it wouldn't just be limited to the sanctuary. People would be able to expand out into other rooms, as long as within each room there are no more than 10 people. Is that correct?
That's certainly the way we are interpreting here in Jefferson County, the guideline. And so, like I said, if you have a place of worship and you have a number of classrooms or Bible study rooms or whatever, we are saying that if you have 10 people in each of those rooms and they are able to keep that social distancing of 6 feet, we do not count that as a gathering for the whole. So if you had 10 rooms, you could have 100 people in your place of worship, and we would not say you are breaking the 10 gathering rule. The place where it gets trickier, though, is in the sanctuary or in the main room. Right now, the guidance we're getting from the state is you can still only have 10 people in that room, even if you have 6 feet between them. And we're looking at that to see, does that really make sense? And can we perhaps get them to change the guidance on that, so that as long as you have separation there, we may be able to expand that. But again, we're kind of waiting to see how it responds in this phase, and we're kind of trying to get some advice on what does a gathering mean. But yes, for all the different rooms, if you are in a separate room, you can have 10 people in there, and we will not think that you are breaking the law.
Thank you. And you had mentioned this earlier, but again, to reiterate, will people over 65 and the vulnerable populations continue to be encouraged to stay at home as we move forward? Do we see that just continuing as is?
yes, we are going to continue to encourage people that are in the high risk group, that vulnerable population, whether it's because of age or because of past medical history. We're going to continue to encourage them as much as possible to stay out of gatherings until we feel we have a really good handle on this disease, or until there's a really good treatment or a really good vaccine, so that we can get them to a place where we feel they're safe to be getting back into the gathering. I know that's very discouraging for people of my age and older, but it is that group that are the most vulnerable to the severity of this disease.
Thank you. A couple people are asking about outdoor venues, the possibility of possibly having a tent set up outside, or just having services outside where there's more space available for people to socially distance. Do we see an opportunity for that in the near term?
Yes, and I would see both of those as two different things. If you have a tent, it's basically like having a building. And the problem with being indoors is that we have the aerosol from somebody who is infected who may not know it. As they breathe, as they cough, as they sneeze, they are passing droplets around throughout the whole building. Even if you have circulation, if it's continuing to circulate it back into the same room, you continue to have those aerosols there. That's a concern. We're not sure exactly what % of the population are getting infected from that kind of circulation, but we're concerned about that. So it is best to go outside. It's best to get outside where you, again, can keep that social distancing. But we are still working with the governor's office and with the state health department to say, okay, if we have 100 people and they're in a large field and they're all more than 6 feet apart from each other, are you defining that as a gathering or not? At the local level, we can be stricter than the state health department or the governor's office, but we can't be more lenient. So we're trying to make sure that whatever we advise, we're not giving you false information based on what the governor and the state health department have determined are gatherings. So we are in the middle of trying to figure that out. We're working with them to get a good definition on that. But as far as I'm concerned, I would feel comfortable having a group out in a large field where they are separated and having social distancing, where the air is clean and you're not passing around so much recirculation of things. So yes, but again, I can't tell you that because the way so far that the governor and the state health department have defined a gathering, they're saying that you can't do that. So we're still working on it.
Okay. And then also, Dr. Johnson, somebody is asking about young children, even with the smaller gatherings of 10, or when we are allowed to have groups of 25 or 50, and you have small children in those groups, particularly possibly in the daycares, at houses of worship. How do you implement social distancing with toddlers and young children that don't know to keep 6 feet apart and would have difficulty doing that anyway?
Well, the quick answer is you can't. It is almost impossible. I have a 5-year-old granddaughter living in my home with me. I have another 2-year-old granddaughter. As far as face coverings, we are not encouraging anybody under the age of 2 to use a face covering, but even a 5-year-old will not wear a face covering in a way that is very safe. And keeping them away from their friends is almost impossible. So as you look at the guidance for childcare and for groups of children, they basically are limiting them to even less than 10 and saying that that group in a childcare situation should never interchange with other groups. So basically what you're trying to do is make a family out of that group, or a family unit, so that you're not spreading people from one group to another, but you are keeping them enclosed within a room as a family group or a unified group, so that they probably will end up spreading everything to each other, but they won't then spread it or get something from another group. So there is guidelines that I can send to you about childcare and the limits of those groups and how you don't intermingle, and also you don't intermingle the staff, so that you basically produce a small group with the same staff member, the same children, and try not to have as much interaction between them and others as you possibly can.
Thank you. This question may be for Christine, but either one of you, I think, can answer it. By closing down and staying at home, are we compromising our immune systems, making us more vulnerable than normal to contract COVID-19 and other diseases?
I'll take that one too, if you don't mind, Christine. The immune system is a fascinating and I believe a creation of God that has kept us alive as long as we are able to stay alive. Many people feel that there are lots of things you can do to strengthen your immune system. That has not been shown scientifically to be as easy to do as some people think. That's because when you talk about the immune system, you're talking about a complete system. It's not just one organ. And there are certain things you can do, eating well, getting good sleep, exercise, all of that seems to help protect it. But it has proved very elusive to boost the immunity, and there's not real good data to do that. The flip side of that is it better to get sick and have your body make immunity to that, or are we causing problems by keeping people from getting ill? One of the goals, or one of the things that we would like to see happen, is to move the population that we have now, where at least before January, we were totally naive to this virus. I thought that was mine, I'm sorry. We thought what we want to do is move that to a population that does have immunity. There's a couple ways you can do that. One is to let everybody get sick and see who survives. And we'll miss the ones who don't survive, but the ones who do survive will be immune. There are some countries that have essentially tried to do that. That's sort of the way the United Kingdom started out. That's the way Sweden has sort of started out. And I'm overstating my case because they did also have some limitation, but it was more than what we have done in this country and some other countries, is basically let people get the disease. They'll either become immune or they will die. What we think is more humane, at least in this country, the position we have taken is, let's let those who do get infected build immunity, but let's try to keep the number of people who get infected as low as possible until we have the ability to give them immunity without them getting sick. That's what a vaccine or an immunization does. And so what we're trying to do is to keep people from getting sick, both not to overwhelm the hospital, but also so that we keep as few people as possible ill and dying as long as we can, hoping that we eventually will either get a treatment so that we can keep them alive until we do get a vaccine, or we get a good vaccine. Now, there's a lot of discussion about, are we ever going to have a good vaccine? That is a scientific question that is above my knowledge. My hope is that we do. I think we eventually will have a vaccine. It may not be perfect. I do not think it will give lifelong immunity, but that's what we are trying to do, is to immunize the population, get them that immunity that way, instead of just letting everybody get sick and see who survives.
Dr. Johnson, I'll pose one final question here before I do the wrap up. And that is, a few people have been asking about the timeline. When might we get to the point when 25 to 50 people will be allowed? And I know that gets a little difficult when you're dealing with advice and guidelines from the state and maybe the CDC as well. But would you venture a guess about that?
I will venture a guess, Sheriff, and then I will give you a caveat. We are suggesting as a public health community that once we begin to open up with the safer at home, that we should watch to see what happens somewhere between 4 and 8 weeks before we move to the next stage, which would be the 25 to 50 level. We then should watch it again for between 4 to 8 weeks before we move to the 250 level. Most of these orders are executive orders that have come from the governor, and the governor seems to be on a little different schedule than we are. And so he could come out this week and say, we're opening restaurants, we're opening bars, we're opening places of worship up to a level of 25 or whatever. So There's some advice we've given that we think makes sense, watching for a couple of the incubation periods. The governor may choose to speed that up a bit faster, as he has done for the most part in all of his orders.
Dr. Johnson, thank you. I appreciate you venturing that and then also providing the caveat. Obviously, for the last 8 or 9 weeks, we all have been dealing with very, very fluid information, at times very fluid, with guidelines coming from the federal level or state level changing as rapidly as once a day when we were early on in this process, and many, many things that none of us had ever believed that we could encounter in our lifetime. I'm guessing that those of you in public health had planned and studied for these things in the past and understand better than most of us could ramifications of them and why some of those decisions are being made. I know there are many questions, and I believe Jenny had sent a note out to those who had been forwarding questions that we are going to log the questions that you've asked that are remaining, because we've gone over a few minutes, but just let me explain this. We will attempt to answer those via via email to be as most efficient. It is our hope with this, as we have approached everything that we have the last several weeks during the course of this, is to provide education and also encourage people to act healthy, to be responsible certainly for themselves, and to be responsible for other people, and to do the best that we can to all get through this. I know that there are questions about First Amendment and what rights do people have. I'm not certainly going to hold myself up as a constitutional expert. And again, we're going to rely on encouragement with these. And I know that that's a question that remains about mandatory or encouragement. We are relying on encouragement. And I'm asking that people comply with the health orders that have been given. And I also thank many of you who've been sending in notes during the course of this, thanking us for doing this. This is not the last Safety and Faith event that we will have. I hope that we don't have to talk about this this topic at the next Safety and Faith, but if we need to, we certainly will. And I hope that before too long, we're back in the position where we can see each other face to face and where we can shake each other's hand. But until then, please stay safe and stay healthy. God bless you. Have a good day.